I'm going to be talking about a condition. I think it's not going to be only applicable for a lot of people's uh, clinics, but also in their life too, because the myopia is very common, and you probably have a lot of family members, friends, kids, they are myopic and they're using glasses. So we're going to be talking from screening to treatment. I don't have any financial interest, so these are the objectives of my talk today. Let's discuss what myopia is. Myopia is known as being nearsighted. This term is an English term, and it's not used in the rest of the world. So it's partially true. But it's not truly a true term. So myopia means the distance objects are blurrier than the near ones, but it doesn't mean that you're seeing the near ones perfectly fine. Depends on the degree of the myopia, you are going to be seeing both near objects and distance objects blurry, as you can see on this picture. Uh, so this is something very common. We get a referral and the patient is having difficulties reading the homework at school or at home. And when we say the kid is nearsighted, the parents ask us, but he is having problems reading up close. But again, when you're nearsighted, it's going to be both blurry, just the distance is going to be blurrier than up close. Why is this important? It is because it's an epidemic. It's a global crisis, and the parents are not aware of it. A lot of the physicians are not aware of it, but it is predicted that 750 million people are going to be myopic enough to need correction by 2050 around the world. So less than 10% of the people are going to be needing glasses basically in 2050. So when you look at this slide, I'm going to go back to this slide again. So the whole purpose of your eyeball, the front part, the corneal lens, is the focus, the light that comes from the object to your retina. Retina is the receptors in the back of your eye. And if your eyeball cannot focus this light where it should be, then you have a refractive error. And we try to correct that with glasses, contact lenses, or other treatments. So why do people get nearsighted? One of them is the axial length. The eyeball grows, like in this slide, too much. And then the light, instead of going to retina, goes in front of the retina. The second reason is the corneal curvature, which means this area on the front changes the light direction too much. And then we have the combination of those things. One of them is prematurity. We see very commonly premature kids turning nearsighted. We don't exactly know why they get nearsighted, but we also know that people who stay in the closed environment, we're going to discuss in a couple of minutes, they turn nearsighted, myopic too. The other reason is connective tissue disorders. Connective tissue disorders, like just Dr. Fabricius just discussed, are going to cause the axial length, the eyeball to grow too much, and the eyeball is going to turn myopic. The last thing is the environmental factors, and we're going to discuss those now because those are the things that we know we can change. So the environmental factors, we know that spending time outside and natural light is very protective to prevent and to stop the progression of the myopia. We don't know the exact threshold, but I'm going to try to explain to you why we think this works. Let's go back. So again, when you get exposed to sunlight, the waves, they get reflected by everything around us. So the areas in your eyeball, they almost all the parts of the retina, they get the light from the sunlight. So you get alerted from the whole retina, almost 360 retina. Versus when you are inside, when you get the screen light, only a very limited area of your retina gets the light from the objects. This is going to be important for us, how we can prevent this to get worse over time. So your body thinks, when you look at a near objects, you do accommodate. Accommodation means you do zoom in. That's how we see things up far and up close at the same time clear. And actually you lose this ability after age 40, 45, 50, and you start using the cheaters. to be able to see up close. But when you constantly look up close, especially the lights up close, your body thinks, hey, this is should be the state of mind for me. I'm accommodating, I'm pushing the light further back. So what I have to do is I have to elongate my eyeball so I don't have to force my eyes to things up close. And as a result, your axial length increases and you become more nearsighted. So what happens when you're outside? You get sunlight, more exposure, different parts of your eyeball, and then you get less myopia. I need someone to mow my grass. If you have a teenager kid that mows your grass, you're very lucky. Help, make sure they stay outside. They help with the yard work. That's very good for myopia progression. Other thing, near work and digital device use, looking at the screens up close, excessive screen time. There's so many studies all over the world show that increases the prevalence of myopia and faster progression. Intensive near work, something we don't want. The screens are even bad, worse. The diet also, there are some studies that shows that processed food and sugar can cause increased myopia prevalence, but also there is a bias with those studies because the countries or the populations who consume more processed foods, they tend to look at screens more as well. So why should we concern about this is because you don't want nobody wants their kids to have glasses unless they have to. But also, we don't see this in the childhood, but when they turn adult, it can cause a lot of problems in the eyes. People who are nearsighted, they develop cataracts faster. They develop glaucoma more likely. They can develop retinal detachment. That's a very severe disorder, can cause blindness more likely. And also, there is an economic impact of using glasses, contact lenses for decades and decades of your life. So how do we detect? First, how as a pediatricians in your office, how you're going to detect? Historically, people used to use Bruckner's test. It's like 3 feet away from the kid, you put a direct ophthalmoscope through the center of both eyes, the light from the direct ophthalmoscope. And if you see a crescent in one eye, that usually tells you there is a difference between two eyes. So it doesn't necessarily tell you the patient is very nearsighted or farsighted, but it tells you there is something off going on. And this has historically has been the screening tool. But nowadays, more and more people are using photoscreeners, their autorefractor machines, and the retinoscopy is how we do our testing. So first, I'll tell you how we do in the office, and then we're going to talk about the photo screening methods. I should tell you that I'm not using any photo screeners. All my patients, I'm using retinoscopy. What's retinoscopy? Basically, this is called objective refraction. This is not subjective. So again, remember I said people accommodate, which means people zoom in. So there is one thing essential when somebody comes to my office, or you come to my office, I'm going to dilate your pupils. That dilation not only helps us see the retina and not just the pupil, but it also takes the ability for you to accommodate. So you cannot accommodate anymore. Kids, they can change their prescription up to 20 diopters when they accommodate zoom in. This is the reason why I get a referral and I hear the parents say, I go to an eye doctor and then every time I see it, I get a different prescription. Every time I see, I get a different prescription. And I ask them, did anybody ever dilated your kid's pupil and checked with after that? And they say no. And I tell them, I'm not sure if your kid is really progressing. It's just like, I don't think your kid ever had an accurate refraction. Because if you try to check their prescription without dilating your pupils, depends on which distance they look, you're gonna get different results. So anyway, what we do is I send light beams through this retinoscope that you see on the picture to the kid's eyes, and basically I see where it falls inside the eyeball. And I put those loose lenses in front and I see with which one I can make that light go to the macula or the retina. And then I change the lenses till I see that light. This is how we check the glasses prescription in kids. So I never use a photoscreener because again, photoscreeners, They can underestimate or overestimate the prescription, depends on where the kid looks. So that's why we always check that, and that's why we always like to dilate any kid that we see in the office. Uh, all right, let's talk about the photoscreening. Photoscreening, remember the Bruckner's test that I showed you? Photoscreening looks at this and depends on the reflex, tells you the approximate of the prescription of the kid. They are very good devices. I should tell you, that's one of the most common questions that I get asked is it okay to use? They're perfectly fine to use. They have very high sensitivity. They have very low specificity, but I'm okay with that. Because when you detect a patient, you'll send us to us, and if they don't have any problems, I'm happy, the patient is happy. We never complain about that. So the American Association of the Pediatrics put a policy out saying that visual assessment by the instrument-based vision screening is endorsed, and it's a valid method, and I agree with that. All right, so I just want to remind you to follow the AAP recommendations for the vision screening. Again, $1 invested in the vision kit yields $36 in terms of academic performance, reduced healthcare costs, and increased lifetime earnings in the patients. Also, prevention blindness, it's an organization. They do have some studies. They claim that as a pediatrician, most cost beneficial screening tool you have is vision screening. It's more cost beneficial than any vaccines that you perform in your office. Let's go back. These are the photo screeners, a lot of the pediatricians that I know you use. The left top one is the eye screen. The middle top one is the spot screening. The right-hand side is the plus optics, and then you have the blink in the bottom. The most common question, and I guess, is there anyone that's better? No. The studies did not show one beneficial over the other. They all do a great job. And the last thing is there is now an phone application. It's called Go Check Kit. It's not free application, but with this one also does the same thing that the photo screening screeners does. It's a low cost and it has an EMR integration, which means it depends if you work with the IT, you can directly upload the results to Epic. The comparison, there are many studies that compares them. They did not show a significant difference between those photo screeners versus the phone application. So what's the treatment of the myopia? Myopia treatment is very simple. Glasses, older kids, we use contact lenses, and you do LASIK after age 21, 22, 23, whatever that age that your prescription stabilizes. But the part that I'm going to discuss with you is how are we going to prevent the myopia progression and control it? So this is a picture. So a lot of the studies that I'll be discussing about the prevention in the next couple of minutes are from East Asia, China, Hong Kong, and India. The reason for that is the myopia is a very, very big epidemic there. Very, very big epidemic there. Usually at average eye hospital they put their 10 to 15% of their physicians for myopia control clinics. So this is a study was published in New England. It shows that if you change the classrooms as if they're outside, then the myopia progression stalls. Look at this picture. You're going to see something. There is no shadows in this classroom. There is no shadows. You don't see the picture. I didn't put that picture, but there are windows all over the classroom. So the kids are getting sunlight all over the surrounding. And also they have the lights all over the classroom, so the kids they don't have to go up close to their books to be able to see them. And then they also mimic that with the trees. They also mimic as if you're always looking far away when you're looking at the teacher. Other lifestyle modifications, these are the things that we know they work. They were proven in many, many, many studies. You're not going to go up close to any books or any screens. And even in China now, they have these things that prevents kids to get up close to their books. Well-lit rooms, always well-lit rooms, as much sun exposure as possible, and spend time outside. We don't want kids to look at bright screens in dark rooms. Always what we recommend is well-lit rooms. Even if you cannot get the natural light, get classic yellow lights. Uh, Always dim the screen's brightness. We don't want screens to be too bright. And also try to limit the screen time. For every 20 minutes, we usually recommend 20-second breaks. This is for eye strain. Now, for myopia control, for every 20 minutes of screen time, we recommend 10 minutes outside time. So there are some contact lenses. They're called orthokeratology lenses. They're very commonly used in United States and the rest of the world. What you basically do is you put a contact lens when you go to bed at night, and it changes the shape of your eyeball, so the cornea becomes flatter and cannot change the light direction too much. And then because they're hard contact lenses, next day your cornea doesn't get back to its normal size. So this is very common uh, optometry practice, but in ophthalmology world, we are not using this very commonly. Why? Because the treatment efficacy decreases over time, and the most common thing we see is when you stop, you have a rebound effect. Of course, every contact lens has a risk of infection, but the rebound effect is the part that we don't like because you're basically saying that, hey, I don't want you to have glasses for the rest of your life. Now you're going to have a contact lens for the rest of your life. Now we have different type of contact lenses. They're called soft multifocal contact lenses. They have a defocus areas in their contact lenses. There is one brand that's FDA approved. So what they do is in these contact lenses, they have different areas. They create a defocus. What I mean by that is these areas, the light doesn't go to your retina where you have the central vision. So the light goes to surrounding areas. So it mimics what the sunlight does with the daily light that you get exposure. So more areas in your eyeball gets exposed to that light coming from outside. Of course, there is a risk of infection for this, any contact lens. That's not the main problem, but the main problem with this is you're not seeing very clear when you have these contact lenses. Also, that's why we try these contact lenses. If the patient is decreasing, they're losing their eyesight significantly, they're not very comfortable on what they see, we usually cannot continue with these contact lenses. So this is an interesting part. This is one of the most common treatments we use nowadays. You're going to be hearing it a lot in the future. Low dose atropine drops. Atropine drops, they dilate your pupil, but also they create cycloplasia. They decrease their accommodation. What I mean by that is when you use these drops, your pupil dilates, so you get more light to your eyeball, but also your near vision decreases a little bit. This seems to be helping with the myopia control. We don't know if is it because you get more light or is it because your near vision is decreasing and you cannot look up close as much. But there are a couple advantages. You just put once a day. You don't have to worry about the infections like the contact lenses. You don't have to worry about the glasses or the kids keeping on and off. The other advantage is you can use it with the kids who have autism, special needs. They don't like to keep their glasses on. They don't like to use anything. There's no way you can put a contact lens in. What are the disadvantages? They are not commercially available in US. You have to have a compound pharmacy to prepare them. And also, they do not treat the myopia. The contact lens that you give to prevent the myopia progression also helps you with the refraction. These don't. If you're -5, even if you use this drops, you still have to have glasses on top of it or contact lenses. But also, a lot of these studies were done from East Asia. There are hundreds of studies that shows that very, very large studies that shows they're beneficial. We did a US study, a multi-centered study, a very big study, randomized clinical trial 2 years ago, and it did not show any benefit in US. So there are other studies, smaller studies in US that show the benefit of stopping the progression of the atropine drops. In US, the study that we did, it did not show a benefit. But there are two problems with the study. We realized that there is more African American patients than the national average. And actually, it's the twice of the national average. We have African American patients in the study. The second problem is majority of the patients were signed up in Baltimore area. So there is a very local area had like 60% or 50, 55% of the patients. And the last problem with the study was it's the recall bias. So we basically just asked the patients if they really use the drops or not. We did not. There was no way for us to control if they use. So now I discuss with the parents. I tell them, hey, we have this drops. They seem to be working in a lot of the studies. We had a major study that did not show they were beneficial. We can get from the compounding pharmacy. There is an FDA approval process right now. So I think it's going to be in December. It's going to be commercially available. But again, this is something I discuss with the parents, and if they really like, I usually let this drop. The last thing is the glasses. One thing I should tell you, there's a very hype 5 years ago about the blue blocking glasses. The studies show that they do not work for myopia progression. They only help with the one bandwidth of the lights. The rest still goes to your eyeball, the abnormal lights from the screens. They do not help with the headaches. They do not help with the eye strain. They do not help with the myopia progression. Basically, they're still being very sold. That's a very commercialized thing. I do not recommend to any of my patients and parents. So now we have two different glasses. They actually seem to be working, but again, they do the same thing. They have a defocus area surrounding the glasses. So except the center that, your eyeball gets more light on the other areas that it's supposed to get. Neither of them are available in US right now, but they're available in Canada. Some parents, when they visit Canada, they get those, or they have family members they visit and they order those through the Canada. So the take-home points: early detection is very important, so we can stop the progression on time. Photo screening works, and go outside as much as possible. All right. And then also I need to say that me and my partner, Dr. Jody, she recently joined us. We're always here to help you whenever you have any questions, whenever you need any help. Even like the simplest things, please do not hesitate to reach out to us. You can send us emails, you can send us epic messages, and we'll do our best to help you.
All right, thank you, Dr. Gunnar. Very interesting. I My favorite picture is the bar for the the Chinese kids at school. That's amazing. We don't have any questions from the audience, and that is it. Appreciate your talk, Dr. Gunnar.
All right, thank you.